There, good afternoon, everyone. Welcome to our Arizona Community Grand Rounds. We're going to give it just a few seconds here to let folks load into the meeting, and then we'll get started. All right, great. Welcome, everybody. We're so happy to have you join us for our November Arizona Community Grand Rounds session. Today, we'll be covering diabetes in Arizona, opportunities for prevention. And many of you are probably aware it's Diabetes Awareness Month, so this is a really appropriate topic for November. I'm excited to dive in and hear from our fantastic experts. First, I'd like to extend a thank you to our partner, the NARBA Institute, who's instrumental in making Arizona Community Grand Rounds possible. And specifically to Mary Jo Gregory, Dr. Mark Carroll, Carla Berg, and Jennifer Pierce for making this whole event come together today. Thank you all so much. Now it's my pleasure to introduce our speakers. I'll give an abbreviated summary of their impressive bios. So first, today we're going to hear from Daniel Rodriguez-Guzman, originally from Mexico City, but a forever Arizonan. Me too, Daniel. Daniel is the program manager for the Arizona Department of Health Services Diabetes Program. A graduate of Arizona State University, Daniel's education is in molecular biosciences and biotechnology, but his experience includes aspects of community health, nonprofit grant writing and management, as well as bench lab work. His hobbies include soccer, guitar playing, scuba diving, and he recently started to learn how to skateboard. That sounds exciting and maybe dangerous. Next, we're going to hear from Vanessa De Silva. Dr. De Silva is an extension specialist at the School of Nutritional Sciences and Wellness at the University of Arizona, and she serves as the director of the CDC-recognized University of Arizona Diabetes Prevention Program, which is available throughout Arizona. Really excited to hear more about that. Dr. De Silva's work effectively bridges the gap between research-based knowledge and the practical needs of communities, focusing on chronic disease prevention and management through diet and lifestyle changes. So with those brief intros, I'm going to turn it over to our esteemed panel. As a reminder to all of you, please feel free to use the Q&A function to send questions our way throughout the presentations. After each of our presenters provides their initial comments, we'll begin answering questions. So you can use that Q&A function at any time during the presentation. Daniel, I'm going to pass it over to you first to give us an update on the state of diabetes in Arizona and all the great work the department has going on. Thank you, Daniel.
Well, thank you for that introduction. Again, my name is Daniel Rodriguez-Guzman, and I am so thankful for being able to come to talk to you about the Arizona Department of Health Services, especially our diabetes program. So I'm just going to pull up my presentation. I'm going to share my screen. It's pulling up. And so we'll start from the beginning. I'd like to, just start off with diabetes in Arizona. Our presentation today is, just a casual conversation. I'll describe the diabetes program at the Arizona Department of Health Services. If you hear ADHS, that is what I mean. And we work very closely, we being the department and diabetes program, work very closely with the Arizona Diabetes Leadership Council and Diabetes Coalition. So I'm just going to give an overview of how we kind of work together, as well as some collaboration highlights and how a community organization, an employer, or just a lay community member, how they can participate with the diabetes people per se. So we'll just dive in, and I'd like to give just a little background in our diabetes snapshot in Arizona. So these numbers right now are taken from the Diabetes Action Plan, which is from the 2023 edition. So that's the most recent edition that we have, the department has published. And we are currently working on finalizing the 2025 iteration of the Diabetes Action Plan. And you hear me say the DAP, that is what I mean, the Diabetes Action Plan. And so just to give everyone here kind of a snapshot in diabetes in Arizona, it's estimated that 1 in 3 have pre-diabetes. So these account for Arizona adults. And it's estimated still that close to 1 in 10 Arizonans will have diabetes. And right now, that 1 in 7 estimated Arizonans live in a food desert. That seems to be holding up as of now. We Arizonans have quite a bit of food deserts here, so that kind of works in the diabetes, food security realm. And just giving a quick little snapshot of diabetes here in Arizona. Pardon me, just pulling up. Oh, I'm just going to go back. So we'd like to present some of our CDC recognized DPPs. So that's the Diabetes Prevention Program. These numbers have changed since then. We're looking closer to 27 DPPs, so CDC recognized diabetes prevention programs. And under that 31, it changed to 27 currently, but we have improved in our recognized DSMES, but Medicare calls it DSMT, as well as access. So we have improved, and we're looking closer to about 67 recognized by the American Diabetes Association or the Association of Diabetes Care Specialists, formerly known as the AADE, now called the ADCES. So we're looking closer about 67. And there's a couple of reasons why we've seen a big uptick on these accredited programs. And just giving kind of an idea of how much diabetes can cost in Arizona. So the American Diabetes Association back in 2017 did this big landmark report doing some cost calculation analyses, where they have found that here in Arizona, just the direct medical costs total about $5.1 billion. And those indirect costs that are from employee absenteeism, loss in productivity, and also early disability, we're looking closer to 1.7. So that's where we get that total $6.8 billion in diabetes related costs. And that's quite a staggering amount. And another item that we'd like to highlight here for our Arizonans is that diabetes carries that higher risk of death for adults with diabetes than those who don't have diabetes. And there's several ways we can prevent the onset, and my colleague here, Vanessa, will go into the very direct, actionable ways to get support for those who are living with pre-diabetes, so that stage before type 2. And from that snapshot, the Arizona Department of Health Services, so we here at the department, we are led by our Arizona Health Improvement Plan. So some of you may be well versed or actually have been included in the planning and the processes of the AZ-HIP, as we call it, which was published back in May 2021. And if anyone would like to dive deeper into the updates and progress, there actually recently there was an update published online, and that's available on our website for updates on these 4 priority areas of the HIP. And so the HIP is that kind of overarching plan that really informs all the programs and bureaus and offices in the department. And just there's a lot of names and and information on this slide, but we just wanted to show the Office of Chronic Disease and Population Health, which is in the Bureau of Chronic Disease and Health Promotion, all at the Department of Health Services. So we are led by Teresa Azrit-Menigoats, who is our bureau chief. And currently we do have some vacancies in our heart innovation and heart disease and stroke program managers positions. But overall, we have grown in the past years due to new grants, new funding opportunities that we, as a department, as an office, have applied for. So we are busy working in all these areas, especially the diabetes program area. And the way our state health programs, or most of them, operate is that Arizona has no state funding for diabetes because we are not one of the 4 leading causes of death here in the state. And that is certainly unfortunate. So as the department, and the way we are able to exist and function is through collaborative agreements. So through federal funding, and for this instance, currently, we are funded through the CDC RFA 2320 is what we call it, the 2320 diabetes grant, or the 2320. And the long name, we call it the diabetes grant, but the long name is a strategic approach to advancing health equity for priority populations with or at risk for diabetes. So that is not just necessarily direct diabetes services, but what's on the periphery of managing and preventing diabetes. And under this umbrella, there were 3 components of this grant, which with different funding amounts, but we as a department went for the component A portion of the grant, where it's essentially non-competitive state funding opportunity, and wherein we had to select 6 strategies, and we selected these 6 strategies to kind of fit and work together. And these first 3 are quite important, right? So we seek to help prevent, but also we can't forget those who have diabetes already. So we want to support those who want to manage. And we, as a state, the state health department, we do not do direct diabetes services. We have that cooperative funding to effectively push out all these funds and these monies to the appropriate community organizations and community programs that have proven track records of very successful community work. And for these 6 selected strategies, we had to identify contractors to effectively do this work. And our first strategy is that diabetes self-management education. And we, year after year, are looking for organizations and different, maybe non-traditional sites that are interested in starting a diabetes self-management education program. And we provide the technical assistance and support to get your standards together and to apply for accreditation, either the ADA or the ADCES. And strategy 5 is our direct support to organizations for the National Diabetes Prevention Program. So organizations across this state that wish to get that support, we had to identify these contractors, and we did identify 5 contractors to have as much statewide reach as possible, with the hope to expand access to these CDC recognized programs. And strategy 7 works to help support those diabetes organizations as well, because we seek to start an umbrella hub. And an umbrella hub will help community, will enhance community work with the experience of a hub organization that can provide billing and claims assistance to those smaller organizations who may not have that capacity. And the following 3 strategies are just as important. And our strategy 9 seeks to support pharmacies and pharmacy groups, pharmacy networks to increase DPP and DSMES activities within our pharmacy groups. And so we have a pharmacist, a consultant who identifies these pharmacy-based program sites. So if you are interested in something like starting a DSMES, so an accredited diabetes self-management program, you can definitely get that assistance from our contractors. If you are a pharmacist or a pharmacy group or aware of pharmacists who would like to dive into diabetes prevention or management work, we do have that support. And also, we seek to support employers, community programs, and the normal average Joe. We want to help everyone find support, and not just referrals, but in access to accredited diabetes and pre-diabetes programming, but those community programs and services that address social determinants of health needs, or that they meet social needs. So we want to increase referrals to, maybe perhaps food pantries, or perhaps mental health screenings, and have built-in screening functions with our referral system. So we look to have electronic referrals between these organizations and entities. And we are supporting that the Community Cares platform with our state agency partner, our state Medicaid access partner. And our recent Strategy 12 CHW strategy, we want to strengthen infrastructure of our community health worker groups here in Arizona. So not supporting direct CHW work, but the overarching infrastructure and technical assistance and support to those CHW groups and networks. Excuse me. So with all that said, these strategies and activities seek to decrease so those living with diabetes, we want to get those A1C numbers from that 9 to that magic number around 7, everything under 9. And we want to increase the number of CDC recognized DPPs, as well as ADA and ADCES accredited diabetes self-management programs, because the hope for having these accredited and recognized programs is to have reimbursement mechanisms, either through Medicare, Medicaid, or form of private insurance or payer. And if you are a payer, you can very much, or a large employer, you can very much have a lot of say in this, where you can support your constituency, your employees by offering, by asking your payers to offer this as a covered employee benefit, the DPP. Currently, we do have, as a state, we have DSMT coverage. So Access does cover 10 hours of diabetes self-management education. They call it DSMT, so that's the training part. But for intents and purposes, we're using DSMES and DSMT as interchangeable. So our project officers and overarching goals want us to see this number in Arizona, the number of program completers go up. We want to see those go up. We want to see more communication between providers, between community organization, between state agencies, to increase those referrals to either DPP, DSMES, or SDOH organizations, as well as screening those for mental health resources. And so some new projects for 2024 and 2025 with our current diabetes funding, we seek to support and scale our diabetes prevention program, technical assistance through our coalition work groups for some professional development and guided sessions. We also want to bring our tribal organizations together for a Tribal Diabetes Health Equity Summit, a one-day event to bring tribal programs and organizations to learn about the current health equity and diabetes related topics, as well as we want to expand our support of the Diabetes Action Plan. And what that means is we want to put our diabetes action plan online and make it very interactive, as well as expanding our media outreach as a health department. So you may see more billboards, or you may see targeted ads that pertain to diabetes and pre-diabetes. And above all, we want to support our CHW networks and groups. And now that leads us into how we work with our coalition and leadership council. So diving back right into that, our coalition is put together, works through work groups, and the coalition helps to reduce the burden of diabetes. So it's an open group where you'll find a multitude of different organizations, as well as different representatives of different communities here in the state. And we want to advocate, well, we, by the coalition, wants to advocate for promoting healthcare policies and programs that improve access to diabetes care, diabetes treatment, management, and educating not only the community member, but as well as healthcare providers and employers. And this group came together way back in 1994 to serve as an advisory council to the state health department. And it was fully formed in 2005 when the advisory council became the coalition. And the diabetes prevention and control program became what you are now familiar with, the Arizona Diabetes Program. And to this day, the diabetes program works with the Leadership Council, which was formally established in 2006 as well. And also to this day, the Leadership Council serves as that advisory entity to the diabetes program. And they really do help quite a bit with the strategic planning of the coalition and managing those work groups. And just a little bit on the structure of our leadership council. We have our executive committee made up of the chair-elect, current and past chair. So this is an opportunity for those leaders within your groups and organizations to dive right into the diabetes arena. So if you you want to take on more, or you feel more civic-minded, or have that duty to your constituency, you are more than welcome to join our work groups. And our work groups need co-chairs. So that is a great way to get into the leadership council through those work group leadership positions. And our work group meetings are open. There's no need to pay anything, or just there's no big commitment. This is a volunteer organization. And I'd like to highlight our current work groups. As you can see, there are some vacancies with our work groups. So this is a great time for folks to jump in, get involved, contact the current work group co-chairs, and see how they can, when those meetings are, what's on the meeting menu per se with groups. And one of those big successes that came from the diabetes program, working with the Leadership Council and Coalition, was the House Bill 2258, aka the Diabetes Action Plan. So back in 2018, Governor Ducey signed the HB 2258 House Bill, essentially requiring us to convene this, if y'all are familiar with like a rock super group, this super group of the DAP report team that includes convening and then providing a minimum of information that is statute-based. So we need to describe the burden of diabetes on Arizona, what we're doing as a state currently to reduce that burden, and kind of some policy and action recommendations for statewide action. Excuse me. And this is a big year-long effort that where we the department's, it is our action plan. We host, we invite everyone, and then it's up to us to finalize it and publish it. So our team involves the Department of Health and our state's Medicaid, both of our state's retirement systems, the PSPRS and ASRS, as well as Department of Administration, and representatives from national diabetes organizations, as well as stakeholder groups. And we have to put together prevalence information because certain elements of our long-term goals require legislative action. So for instance, diabetes prevention program coverage by Medicaid would need legislative action. And so legislators and policymakers always want data, right? Decisions made driven by data. So what does that mean? We put together, these agencies are required to submit this information. We look at the information and then we provide those recommendations to the state. And if you'd like to learn more, the Diabetes Action Plan will be published on or before January 1st of 2025. And another great collaboration that came from working with the coalition groups is that we work with the coalition to target geographic areas, but also priority populations. And historically, we had outdoor billboards with pre-diabetes messaging. And we also developed posters and flyers for available for download because COVID really affected everything in person, printing. That kind of all went out the window. Everything kind of went more virtual online. And that's why we really invested historically with digital and print ads. We are going more digital nowadays. And some of those pre-diabetes media pieces that came out were to support our national diabetes prevention programs. Also, we had this Mission Possible element of our messaging. It's now defunct, and we're working on that with our current funding to update the messaging and call to action, which includes the Agents of Change community program action element. And so these are some examples of our pre-diabetes messaging. You may have seen it through targeted ads or on billboards, but we really wanted to draw attention that pre-diabetes will eventually equal something. So heart, pre-stroke, pre-heart attack, pre-kidney disease. And it was very well received within our Latino communities. So we did get these translated into Spanish. Our Mission Possible was our call to action for community members to take their risk test, and for employers and larger organizations to promote to have people go take the risk test to know their level of risk to join either a diabetes prevention program or a diabetes self-management program. And gave you some information on what pre-diabetes is and some actionable steps. And here is the online version of that risk test. It still is live, and it still is valuable to have your constituents and your people take that risk test, know their level of risk, and act on that. And one of the Agents of Change portions of our messaging asked providers to establish their team and establish referral processes to accredited or recognized programs. This right now is going through our refresh and reimagining, and we will have a refresh on the color palette and action steps in the next several months. Our contractor is working to get all of that created for us, as well as the diabetes messaging. And this is just an example of downloading that toolkit as a healthcare provider. Here's some helpful links to our diabetes program website and to that risk test risk test. Also, our homepage for the Department of Health, our landing page, and that risk test you can share to your people. And here's just a screenshot of our diabetes program webpage and how you can engage. You can refer to accredited or CDC recognized programs. You can share the link, take and share that risk test, join our work groups. That is going to be a great way to get into the mix of things, get involved, be up to date on new collaborations, new funding, and also contact the diabetes inbox at your leisure. And I think I'm at time, and I appreciate everyone for their time. And for any questions, you can feel free to email diabetes@azdhs.gov and also email me directly if you would like. That is our office line, and you can, we're not in office for the next couple of weeks, but if you do leave a message, we will get back to you as soon as possible.
Daniel, thank you so much for that. Those were fabulous resources and information that you shared, lots of different ways to get involved. Really helpful. I'll remind all of our attendees that we will have a recording and the slides posted after in a couple of days, so you can check back on the NARBA Institute website, because Daniel had a lot of links and things on there that I think might be of really great interest to all of you. Also, as a reminder, if you've got questions, you can put them in the Q&A section on Zoom, and we'll get to them as time allows on the end, or can follow up after the fact. But at this time, I would love to turn it over to Dr. De Silva to share more about what they're working on at the U of A, and also just about diabetes prevention programs in general. Vanessa, please take it away.
All right, thank you. So let me just go ahead and change this. So what I'll talk about is something that Daniel mentioned already a couple of times, was the Diabetes Prevention Program. Usually you'll hear me call it the DPP. The DPP is based on robust research that I'm going to go over in for the next few minutes. I really try to compare the impact of intensive lifestyle intervention, or encouraging people to make some lifestyle and dietary changes, compared to metformin, a common medication that is given for people with diabetes, but is also given for people with prediabetes nowadays, and placebo. So to sort of take a step back, first, I did want to say something, or remind everybody of something, is that while about 1 in 10 Americans have diabetes, and most of those are type 2 diabetes cases, 1 in 3 American adults have prediabetes. So that's around 98 million was the last number that was released, 98 million adults with prediabetes. So it's a huge, huge public health issue. Prediabetes being a stage where your blood sugar is higher than normal, but not quite high enough for a type 2 diabetes diagnosis. And what this study here that I'm about to show you really was able to show was that you can reverse prediabetes through lifestyle changes. So what the study did, and this study was, the report is from 2002, but the study began in the late 90s, and recruited over 3,000 people who had a clinical diagnosis of prediabetes. They were over the age of 25, and they had a BMI of over 24. Those of the study population that were Asian American had a BMI over 22. So they were all given standard lifestyle recommendations of, eat healthier, move more, and then randomized into 3 groups: an intensive lifestyle intervention, metformin twice a day, or placebo. And then they were followed, and that's the cool part about this study, is that these study participants were followed for initially 3 years. So the intensive lifestyle intervention had 2 main goals, which were for participants to achieve a weight reduction of 7% at least of their initial body weight, and to do this through healthy eating and physical activity. The physical activity goal was aimed at expending an extra 700 calories a week give or take. That translated to make it more easy and also make it in line with the government recommendations for physical activity, 150 minutes a week of moderate activity. So really they focused on brisk walking. That seemed easy enough for most people. They were also assigned fat gram goals. So they were also told in terms of their dietary modifications to keep their fat to under 25% of their total calories. That was to help with that weight loss. If the weight loss was not happening, then some were also given calorie goals that would bring their calorie intake pretty low. So 12, for example, if the participant or study subject weighed 140 to 170 pounds, it was 1,200 calories a day, so which is pretty low, but to encourage that weight loss. And what the intervention was, it was 16 meetings, 16 lessons over 24 weeks, or about 6 months. This was one-on-one with a registered dietitian or a case manager, they call the lifestyle coach. And that person was giving those participants, those study subjects, individualized support, help with problem solving. They also had supervised exercise sessions that were made available twice a week. So that was the first 6 months. And then they still were touching base with their case managers, either by phone or in person. They also were given what we call incentives, or things that will help you with that behavior change. Sometimes it is like access to a gym, sometimes it's exercise videos, access to a personal trainer, cooking classes. All these things are what I would love to be able to offer more of in our cooperative extension programs. And in this case of a well-funded research study, they were able to do this. This was a really a best case scenario for these 1,000 people or so in this group. So realize that this is very intensive and also very expensive. But that was the whole point. They wanted to see, how did this best case scenario work? So here's some data. I'll be showing a lot of the data because it's easier just to visualize, what they are trying to tell. So the intervention was the first half, the 0.5, right? The 6 months was that core, and then another 6 months of less intensive. And I think they were touching base throughout the 3 years after that. But really the intervention, the intensive program part was at those first 6 months. The goal, remember, was 7% weight loss. That was achieved by around 49% of the participants at the end of those 6 months. By the study end, that number was up to only, or decreased, I guess, to 37%. But look at the physical activity. So the lifestyle intervention increased that physical activity, and then it kept it up over the course of those 4 years there. And if you, I don't have it on here, but if you keep on looking further, that activity remained higher than the placebo and the metformin groups for another couple years, until it sort of came back down and was in range with the other two groups. But at this point was when the initial DPP trials were completed, and they were able to look at incidence of new cases of diabetes in these 3 cohorts. That was the whole point. What was the incidence after 3 years? So compared to placebo, which, if you remember, placebo got just standard lifestyle recommendations, which was like a 20-minute visit with a dietitian going over some best practices, and then placebo, and then metformin and lifestyle. Compared to placebo, metformin twice a day reduced the incidence of new cases by 31%. So 31% fewer people in that cohort developed type 2 at the end of those 4 years there, at that 4-year mark. And the lifestyle change group, it reduced it by 58%. So this is why you might see in those outdoors and stuff that Daniel was talking about, sometimes when they're talking about the diabetes prevention program, you'll hear them say it cuts the risk in half or by half. This is where those numbers are coming from. Especially interesting is to look at older adults and the impact on older adults. So in older adults, the risk reduction was 71%. So the lifestyle change intervention was particularly helpful and effective in older adults over 60, which was incredible. Interesting side note is that then the inverse happened with metformin. It was more effective in the younger age group within those 1,000 people that took the metformin. So that was pretty robust. They're like, okay, this really worked. So what they did at that point was they invited everybody to stay on in the study to see what keep on following them longitudinally, but they also, out of ethics, offered the lifestyle change program to everybody. So the lifestyle cohort got it again if they wanted this. At this time, it was a modified one that was group based, but it was also 6 months. And metformin and the placebo groups got that lifestyle change program as well at that, what they're calling the bridge period between the DPP and what they call the DPPOS. You'll see slides about that in a second. This was another cool graph that they were trying to look at the individual goals and so this graph is only showing results from people from the intensive lifestyle intervention group. So and here on the left-hand side, you're seeing the goals of the weight loss goal, the exercise goal, and the fat goal. Remember, that was to be under 25% of your total calories, so really reducing that fat. I will say that is no longer one of the recommendations for diet for people with diabetes now. The ADA has a more flexible approach where if that is what works well for somebody, then yes, let's reduce the fat, but they also are acknowledging that there are many dietary patterns that can be suitable for somebody with diabetes. That was just a side note. So if you look here, the people that met all three of the goals, those actually, the risk reduction in that subgroup was, I believe it was 89%. So that 58% that I showed you, that was the average amongst the 1,000 participants in that arm of the study. But even folks that didn't meet the weight goal, for example, so I will look at number 2, 3, and 4. They didn't meet the weight goal, but they met the exercise goal, and they may or may not have met the fat goal. That also did help reduce the risk for new cases of diabetes or progression to diabetes in these participants with prediabetes. But what this paper concludes is that the dominant determinant of reduced risk in people with prediabetes was weight loss. So this is why you see a strong emphasis on weight loss in the diabetes prevention program and in any care for somebody with diabetes or prediabetes. So the DPPOS is this study that I told that has followed these 3,000 people that till today. So the risk reduction remained. So this is 15 years out. You can see that metformin and lifestyle are becoming, at this point, they're no longer significantly different after 15 years, but it is still lower than the placebo. This study, the DPPOS and the DPP, is the largest continuously running diabetes prevention study that is still actively following the participants, which is really cool. And what they are looking at now, as you know, this has been more than 20 years, they're looking at, are there long-term effects of either the lifestyle intervention or the metformin intervention on complications from type 2, on a cognitive decline as people age? Because now these people, the average age now, they're in their 70s. So they're looking at all these really interesting things, neuropathy, nephropathy. I mean, there's all sorts of different microvascular effects. So it's really cool that they get to follow these people till today. But the best part of this, or the most important take-home message, is that even after 20 years, the risk reduction persists. So even though you see that compared to placebo, whereas initially 3 years out, we were at 58%, 20 years out, we're at 25%, it's still a risk reduction. And same with metformin. So the prevention effects remain. And in the folks that have not developed type 2 yet, or never have, they saw a lower risk of micro and macrovascular disease. They saw overall, when they're looking at this point, so now 22 years out, they're saying there is not really seeing that benefit of metformin or lifestyle compared to placebo on heart disease development or kidney disease or any complications. But you see favorable trends in cancer risk in, that was with the metformin, stroke reduction, cardiovascular events, reduction of frailty in the participants of the intensive lifestyle change. So clearly, hopefully, there is no doubt in your mind that the intensive lifestyle change program here was effective. Another important thing to keep in mind is the United States was not the only country to do this kind of work. This exact type of intervention of comparing lifestyle change with placebo and all that was done in China and Finland and other countries, and they all showed the same powerful protective effect of this intensive lifestyle change interventions. But as I mentioned, it was pretty labor intensive, pretty costly. When I tried to calculate in today's dollars, it was around over $6,000 per participant. So again, this best case scenario. But we have 98 million people that we have to help, or that should be helped, right? So how do you then translate this research into practice? And that's the National Diabetes Prevention Program initiative from the CDC. And so that was launched in 2012. CDC provided a curriculum in English and in Spanish. They make this now where the program is not one-on-one, it's in group form, and you do not have to be a registered dietitian or a registered nurse to deliver the program. The lifestyle coach just needs a 2-day training. They could be a lay educator, and that all of these are meant to bring the costs down. The other thing that has changed is that now Medicare, given those amazing impacts on older adults, Medicare does cover for the diabetes prevention program in some states, not Arizona yet. Medicaid does too, and some private insurance plans do cover or reimburse for the diabetes prevention program. So this is a year-long program that they've made. It's 26 lessons over the course of a year. The core being those first 16 lessons that focus on building these fundamental skills around diet and physical activity and monitoring. So that's, if you look at the session titles, you'll see that. And then sessions 9 through 16, the rest of that core focus on coping strategies and thinking about, reframing stuff. What are the other elements around behavior change? So they do that. And then sessions 17 to 26 is really just more of the same, repeating that again, so that the participant has support over the course of a whole year. There is no longer a dietary fat goal. There have been 3 iterations of the DPP, national DPP curriculum. So in 2017, when it changed from the original 2012 version, that dietary fat goal was no longer included. Now, again, like I said, they really focus on a healthy dietary pattern. I have a picture here of one of the pages from the module that talks about eating well, or one of them, and it shows the diabetes plate, for example, which is more flexible. The goals for this program are in line with the goals for the original trials. Instead of 7%, they're saying 5% weight loss and 150 minutes of physical activity. So those are the goals that for the accreditation process, they're looking for participants to meet. In recent years, they have added a third goal, which was a decrease in the participants' A1C by 0.2%. So over the entire, so pre-post, meaning at the beginning of the year, at the end of the year. And these are self-reported. We do not have to measure it ourselves, or again, we're not a clinic, my particular program. So for us, it's self-reported. And so then this is data from the CDC, because what we do in order to be accredited is we have to submit our data twice a year, all of our participant data in a very particular format to the CDC. The CDC has been aggregating all the thousands of organizations across the country that deliver the program. And this paper here, they were publishing data that they collected between 2018 up until right before the pandemic. 2012 to right before the pandemic. So cohorts that started in 2018. And one thing I didn't mention is that the program can be delivered in person. It could be delivered like this over Zoom, we call distance. It could be delivered asynchronously online. So we're just a self-led DPP with some opportunities to chat with a lifestyle coach, and then a combination mode, which usually will involve some live and asynchronous component to it. So this is retention. I think one of the things that Daniel was mentioning was increasing the number of participants who complete the program. To complete the DPP, you are a completer after 10 months, after you've attended one session after the 9-month mark, or around 22 sessions, which is what this y-axis is here. So you'll see that the highest retention is among in-person participants. It's around 23%. People remain at the end, and the lowest is in the combination cohorts. So you will see that by the halfway point, look at around session 16, the in-person still have maybe half of their participants, and the others are down to around 30% of their participants at the 6-month mark, give or take. What about the outcomes? This, again, nationally aggregated. These data reflect, I believe it was over 300,000 participants that over those 6 years. The weight loss, well, if you look at the very left part, you'll see that not everybody, number one, loses weight. Most people do lose some weight, but there are some people that gain weight. This is a whole year. Life happens. Not everybody is in a place where they are able to make the lifestyle changes that we are encouraging. So the average weight loss is around 4 to 5% in the in-person and distance led DPPs, and lower in the online and combination. Again, these are data through 2018, so the CDC hasn't yet published on more recent data, but you will see that that's what they are experiencing overall across the country. Our program is through cooperative extension at the UofA. So the last couple of minutes, I'll share about our program. We the map you'll see here has in the lighter blue or the more turquoise blue, those are the counties where we have educators physically located in those extension offices. We have extension offices, at least one in every county, all of our 15 counties for cooperative extension. And they are housed in those offices are extension faculty and staff, extension professionals that, amongst other things, do direct education outreach, such as the DPP. So we offer our program in person or over Zoom. We have both modalities in English or in Spanish, depending on which educator is leading that cohort. And due to our partnership with ADHS, with the contract that we have with them and funding from Cooperative Extension, we are able to offer our program free of charge to eligible participants. Is one of the conditions of the contract with the CDC is that we are reaching people who are at risk for prediabetes and not, for example, people with type 2. But with our funding from Extension, we really try to have our program open to everybody. We do not like turning people away. We do not bill insurance yet. I don't know. That's something that we're trying to make happen. And no physician's referral is required. Anybody's welcome to join our program. They do not have to have insurance or show anything. They just join our program. That's part of our mission as Cooperative Extension, is to reach Arizonans who need support. We have been around. Our first cohort started in 2018. Since then, we have seen over 500 participants from all 15 counties. That was especially because since we've been in Zoom. Our reach, meaning count where we are physically located, and also the number of people we're able to reach, is really just limited by our funding. Because the potential is there, the infrastructure is there, and absolutely the goodwill is there to reach more people. We have Full Plus, which is the highest level recognition for both of our in-person and distance programs. Our participants lose on average 5.3% of their body weight. And if you remember that retention, that first graph I showed you, that was around 20 to 25%. Ours is 60%. 60% of our participants complete the program. We have excellent retention, and this is kudos to our educators who are amazing. We did some cost savings, cost effectiveness calculations using our own program data, our own cost and our own retention outcome numbers. And we saw that for every dollar that was invested into our UofA extension DPP, over 5 were saved in direct and indirect medical costs. We also have conducted a small study looking at what other impacts beyond just weight loss and A1C reduction that our program is having. And we were able to see that there is, first of all, on the participants themselves, impact on their other metabolic health markers, blood pressure, cholesterol, sleep, mood, joint pain, but also impact on their household members, their spouses, their children, which is incredible. And that is something that I will be looking into doing more robust research around, because I love that. And then just to the referral, what can you do if you have somebody who you want to refer to a diabetes prevention program? I got this from the CDC registry of DPP organizations. So that's what the 27 that Daniel mentioned. You can see that most of them are in person, and you can also look at the map of our state and see how much more work we have to do in terms of getting more organizations, more representation. I will also say, though, that, for example, UofA Cooperative Extension shows up as being in Tucson, because that's where the address is that I put, because we have one organization but we are actually statewide. And I would imagine that some of these others that are listed here are the same. So that maybe this map is not exactly representative of the reach of DPP in the state. And then I just wanted to share the Access Community Cares that Daniel mentioned, the electronic referral platform that will be, so hopefully some of you are going to be using and being able to refer to diabetes prevention programs, including ours, in the near future. And with that, I wanted to leave a few minutes so that people might have time for questions. My email is here if anybody has questions, and people can sign up for our program on our website, preventdiabetesaz.org. Thank you so much.
Thank you so much, Dr. De Silva. That was an excellent presentation, great review of the evidence base behind diabetes prevention programming, as well as some of the great resources here in Arizona, and links to where folks can find those to refer patients, friends, family members, all of that into DPP programs as well. Both of our panelists also mentioned community cares. For those who want to dive deeper into that, we did a session on community cares in the closed loop referral system through Arizona Community Grand Rounds a couple of months ago. So you can all go ahead and check that out on the NARBA Institute website as well, if you're interested in just learning more about that closed loop referral system. At this time, I think we're gonna close out without questions today, just because we're almost at the top of the hour, and I know probably most of you have 1 o'clock meetings to get to. But I want to thank our panelists so much for their time today, and just a load of really important information. Great work happening with diabetes here in Arizona, and I encourage everyone in attendance to go check out those slides and recording once they're posted on the NARBA Institute website. Daniel, Vanessa, thank you for your time today, and everyone else, I hope you have a great rest of your week. We will come out with some more information about our next Community Grand Round session here in the next few weeks. Thank you all so much. Bye.